Good morning, friends. This is Dr. Sanjeev Gulati. I'm Chairman, Nephrology and Kidney Transplant for Fortis Group of Hospitals, NCR. Uh, at the onset, I'd like to thank the scientific committee for inviting me to give this talk. At the same time, my sincere apologies for inability to come because of some pressing family circumstances. So I'll be talking about anemia and chronic kidney disease, leveraging evidence-based treatments for current practice. When I think of anemia of CKD, I am reminded of this quote by Alvin Toffler that the illiterate of the future are not those who can't read or write, but those who cannot learn, unlearn, and relearn. In that sense, many of us from my era have had to unlearn some of the past treatments of anemia, which involved just blood transfusions, anabolic steroids, and we moved on to erythropoietin, and now this is an exciting era where we have now newer agents, namely the PHI HIF inhibitors. First of all, starting with an actual case that I've been managing over the past few years. This is a 24-year-old male weighing 63.9 kg. He's done his BTech, he's employed, and he plays cricket and does cycling. Also does an annual trek to Vaishno Devi, a Hindu shrine, which involves a 14-kilometer arduous trek. Now, why am I telling you this? Because he is a patient who had CKD at 2.5 years of age. But because of erythropoietin, we were able to maintain hemoglobin of 10.7 to 11.4 with the creatinine. His last creatinine was 4.5, so EGFR of 18. But you can see the quality of life thanks to erythropoietin. He can do everything which a person of his age would be doing. Now, overall, the CKD's reported prevalence is about 9.1%, ranging about 8.5 to 10%. And what is important is as the stages severity of CKD increases, the prevalence of anemia also increases. Although the earlier stages of CKD, we all know, are more common than the advanced stages, but the anemia was twice as prevalent in patients with CKD in the general population, 15.4 versus 7.6%, and prevalence of anemia was 8.4% in stage 1 to 53.4% in stage 5 CKD. In India, it is estimated that the CKD patients, percentage of CKD patients who are requiring erythropoietin are anywhere between 30 to 35%, which is about 3.5 lakhs, and these are the non-dialysis patients, and among dialysis patients, it is about 1.72 lakhs. Now, there are two major players in erythropoiesis. One is erythropoietin. We all know that. It acts on the burst-forming cells and the colony-forming unit erythroid cells. It transforms them into erythroplasts, reticulocytes, red blood cells. But as you see here, iron incorporation is very important for an optimal erythropoietin action, and therefore iron-restricted erythropoiesis results in red blood cells that are hypochromic and microcytic. Now, these are the key recommendations for the most recent anemia guidelines. The KDIGO says that once, ESR should be given if the hemoglobin is less than 10. The KDOKI also showing similar guidelines and with targets of anywhere between 12 to 13 that have been recommended. And these are the iron recommendations for iron supplementation and iron monitoring. You all know that. Now, this is the management of CKD anemia as per the KDIGO guidelines. It's available in all standard textbooks now, also on the net. It's a busy slide, but first and foremost, what I want to say is that yes, you should evaluate all CKD patients for hemoglobin. At the same time, look at serum B12, folate, and iron studies, and then try and work downwards as to if there is iron deficiency. First, supplement iron either orally or intravenously, or there are vitamin supplementation is required. And if everything is replete, then we can embark on the erythropoietin therapy. Now, these are the benefit of treatment options available for management of anemia and CKD. And, when I started my training in nephrology, we were mainly dependent on blood transfusions. Did improve anemia related symptoms. It still remains an option when rapid correction is required, an option for patients with chronic anemia in whom ESA synthesis is ineffective or detrimental. Then came the oral iron, wide and easy widely used, easy to administer, relatively inexpensive, avoids frequent outpatient visits, and new formulations are available, which increase absorption. It was followed by the intravenous iron, which bypasses the need for GA absorption and is incorporated more rapidly than oral iron into red blood cells. We have fewer administrations required to reach the target hemoglobin. It may delay or avoid the need for ESA therapy, and it suggests that the benefits for IV iron outweigh the risks, and newer oral irons are very safe. The ESAs were heralded a sea change, a new era in the management of anemia, and we have new formulations that are coming in. ESA therapy corrects anemia, and CKD shows clinical benefits and reduces the need for blood transfusions. Blood transfusions have their disadvantages in terms of sensitization, especially for patients who are planned for kidney transplant. So they are best avoided nowadays. We know oral iron has a lot of side effects and which interferes with compliance. Intravenous iron now is can be used. The newer irons are very safe, but yes, they do require staff and facilities for monitoring, but very minimal side effects. ESAs, are expensive. They're the largest drug cost for CKD or end-stage renal failure. 15% of these patients may not respond. And the KDIGO recommends great caution or avoidance of ESA in patients who have stroke, history, active malignancy, or there is history of malignancy also. So let's see what are the unmet needs with current therapy and the need for shift to newer therapy. ESAs, there is a progressive reduction in response or hyporesponsiveness, and we know that studies have shown, notably the CHOIR study, increased risk of adverse cardiovascular events, hypertension, stroke, thrombotic events, MI, heart failure related hospitalization, all cause mortality, cancer progression, diabetic retinopathy, and pure red cell aplasia. We all know that occasionally we see these patients. Intravenous iron, there is risk for bacterial overgrowth, GI side effects, hypersensitivity, and risk of infections, mortality, cardiovascular risk. So there are several challenges of the anemia management, namely inflammation, diabetes, cancer, hospitalized patients, patients who receive a kidney transplant. These are very challenging scenarios. A very important aspect that we have realized over the past few years is that there is reduced responsiveness to ESA in states of inflammation, which is erythropoietin resistance. About 5 to 10% of these patients with CKD will develop hyperresponsiveness, which is defined as a greater need for the requirement of ESA more than 300 international units per kg or 1.5 microns per kg of darbepoetin. And this hyporesponsiveness has been shown to contribute significantly to mortality, morbidity, healthcare economic burden in CKD, and it poses a diagnostic and management challenge. And the commonest cause of ESA resistance is either non-compliance, absolute or functional iron deficiency, followed by inflammation. So this is ESA resistance. We work down. If there is iron deficiency, you would supplement iron. If there is no iron deficiency, you look at all these causes. And among these, non-compliance, absolute or functional iron deficiency, and inflammation are probably the most important. So what is the burden of ESA responsiveness? These are the different differences between ESA hyporesponsive patients. About 12,361 was studied in this study compared to normoresponsive patients. And as you can see, the IV iron use was significantly higher here. Similarly, the ESA was significantly higher, the PTH was higher, hemoglobin was lower, ferritin as well as transferrin saturations was significantly higher in the hyporesponsiveness group. And compared to normoresponsive patients, ESA hyperresponsive patients face the following challenges: significant higher responsiveness of IV iron and ESA, achieve lower hemoglobin, and worse iron metabolism as reflected by higher ferritin and lower transferrin saturation. Now, there is now newer understanding of CKD anemia, namely the important role of hepcidin. So which is released by the liver, especially in states of inflammation. Now, hepcidin acts on the kidney and normally it stimulates erythropoietin production, but in stages of uremia, there is reduced erythropoietin production, reduced renal clearance. But hepcidin has a very important role acting on the GI system, and it prevents the absorption of iron from the GI system, from the duodenum. It also prevents the release of macrophages, iron from the macrophages, so thereby causing a state of functional iron deficiency. And thereby, so once you do not have enough readily available iron, the anemia is worsened. Now, inflammation plays an overriding role, as we are increasingly realizing in anemia and EPO resistance and chronic kidney disease. There are several cytokines which are released, which affect the liver, which increases the hepcidin release and causes iron deficiency. There are others which affect on the kidney, reduced EPO production. There are these cytokines which act on the bone marrow and decrease the erythropoietin blast forming units and again contribute to anemia. There is oxidative stress, mononucleophagocyte increase, which acts on the blood vessel. It's a shortened RBC survival, contributing to anemia, erythropoietin resistance. And this is a study which was published in Kidney Medicine 2020 as to how does ESA responsiveness affect clinical and economic outcome. A US RDS cohort of 834,000 patients was looked at on 6 months of continuous ESA use. It was found that ESA hyporesponders required nearly 4 times higher ESA dose and 5 times ERI resistance. The baseline characteristics, they were more often younger, females, had hyperparathyroidism and higher Charleston comorbidity score. There was a significantly higher risk of cardiovascular event hospitalization in the hyporesponders and higher healthcare resource utilization rates also. So the study concluded that ESA hyporesponsiveness in dialysis patients is associated with higher mortality, higher cardiovascular hospitalization rates, and healthcare costs. So something we need to keep in mind and manage. So management of anemia of CKD in patients with inflammation, you need to consider both the systemic inflammation as well as the exacerbation of anemia in CKD. And inflammation is indicated when the serum ferritin levels exceed 500. It is accompanied by a decrease in the hemoglobin and transferrin saturation. For maintenance of hemoglobin levels, higher doses of IV iron or ESA are required, and they in fact contribute themselves to increased hepcidin production, leading to a vicious cycle. So this is a slide talking about the treatment of anemia and difficult to manage patients with chronic kidney disease, which are anemia of inflammation, type 2 diabetes, cancer, hospitalization, kidney transplant patients. The inflammation causes reduced hemoglobin levels, and the clinical trials of HIF-PHI inhibitors in patients with non-dialysis patients and dialysis-dependent CKD patients have shown that they have increased hemoglobin levels, increased EPO levels, and may improve iron utilization regardless of hospitalization. So the study concluded that management of CKD is challenging in these patients, but there are new treatment options, namely HIF-PHI inhibitors, which may improve outcomes. Risks associated with ESAs, certainly to be kept in mind. Most common side effect is hypertension, and renal anemia is a factor predisposing to increased blood pressure due to increased sympathetic activity and impaired nitric oxide availability. And there is an increased risk of thrombotic events too. So the risks are pure red cell aplasia, accelerated tumor growth. Higher doses of EPO can stimulate endothelial and vascular smooth vessel cell proliferation, promote angiogenesis, and the anti-apoptotic pleiotropic effect of EPO can contribute to tumor disease progression. So when we are talking of a patient of anemia, we need to look at, for optimal iron and anemia management, look at iron, look at ESAs, but also look at inflammatory states, because it is here that there are newer agents which are available at our therapeutic armamentarium. And this is the journey of CKD anemia. You had prior to 1950s, just management of blood transfusions, then IV iron dextron, high incidence of side effects. In 1989, EPO was approved. Then darbepoetin came in. Then the iron sucrose came in. Then we have the newer irons, namely peroxycarboxymaltose, iron isomaltoside between 2007 and 13. Then the 2012 HIF-PHI inhibitors were marketed. Now we currently have four HIF-PHI inhibitors: the varoglutamstat, molidustat, anorlustat, and daprodustat. And then deciduostat was the most recent one, which was approved in 2022. This is the DREAM-D study looking at the deciduostat for the treatment of anemia in CKD patients not on dialysis. And It was a phase 3 multi-center open label study. I happened to be a part of this trial. So what we did was we enrolled patients who were between 18 to 80 years, between stage 3 to stage 5 patients who were not on dialysis, hemoglobins anywhere between 7 to 10. The deciduostat arm received 100 milligram 3 times a week for about 6 months. The target hemoglobin range was 10 to 12. This is the primary efficacy. We enrolled 588 patients, 261 in the deciduostat arm, 268 were given darbepoetin alpha, and what we saw was the deciduostat was non-inferior compared to darbepoetin in the treatment of anemia and CKD patients who were not on dialysis. So safety was comparable to darbepoetin, and this is the treatment-related adverse events, which was similar in the two arms, and side effects again were not related to the investigational product. This is the ND study looking at anemia parameters. As you can see, this is the mean hemoglobin, this is the ferritin, this is the serum iron, and this is the transferrin saturation. So there was improvement in the hemoglobin, serum ferritin, transferrin, serum iron comparable, and it was comparable to the darbepoetin arm. As you can see, this is the blue is the darbepoetin arm, red is the deciduostat arm, and the transferrin saturations were actually significantly lower in the deciduostat arm as compared to the darbepoetin arm. This is the DREAM-D study, and again, I was a part of the DREAM-D study where we looked at the HIF as a normal transcription factor which plays a central role in physiological response to anemia, and deciduostat being an HIF-PHI inhibitor has been proven to be effective in increasing hemoglobin levels in anemia due to CKD. So we recruited 184 patients in the deciduostat arm, 189 patients in the erythropoietin arm, and these are the secondary endpoints that we looked at. To sum up, deciduostat was found to be non-inferior compared to erythropoietin in the treatment of anemia in patients with CKD who were on dialysis, and the safety, as you can see, the side effect profile was similar: 8.16% in the deciduostat arm, 10.7% in the epoid and none of these were related to the investigational product. And this is again the DREAM-D study looking at the anemia parameters, and the effect of deciduostat increasing the hemoglobin levels was compared to epoprotein alpha, and similar effects were observed in serum iron, transferrin, and serum ferritin. Adverse events again with deciduous therapy, both the trials did not show any significant adverse events compared to erythropoietin. These are looking at the cardiovascular events, which are comparable between the Darbo as well as the oral deciduostat arm, both in the DREAM-D study as non-dialysis as well as the dialysis study. Now, there are certain other benefits of clinical HIF-PHI inhibitors, and one advantage is that it is an oral route. It increases or maintains hemoglobin effectively. It increases endogenous EPO production in the physiological range. It regulates hepcidin, which I showed you is a marker of inflammation, and it increases iron absorption by inhibiting hepcidin, and it is not influenced by inflammation, unlike ESA. The inhibition of HIF-PHI is reversible, it is transient, there is no risk of hypertension, and there are also pleiotropic effects like lowering of cholesterol levels, avoiding of high EPO levels, and avoidance of side effects associated with IV iron administration, which is reduced. Now, there are certain concerns that remain, obviously. First of all, till date, we don't have long-term safety data, and you should be cautious in using these patients who have malignancy, who have diabetic retinopathy, liver dysfunction, hyperkalemia. I think potassium should be monitored, but this is inconclusive, and this is similar to erythropoietin. Hypertension, again, similar to erythropoietin. Pulmonary hypertension, heart failure. I think so far safety data is not available. Thrombotic events, vascular calcification remain a concern. There is concern regarding cyst growth, so one should avoid this in patients with polycystic kidney disease, and seizure disorder. Clinical studies have not shown any signals that have related to PHI HIF inhibitors. These are the hepcidin levels in the deciduostat arm. So as you can see, at week 12 and week 24, there was in the darbepoetin arm, this is the this is the hepcidin level. This is the in the deciduostat arm, and there was actually an increase in the hepcidin levels in the darbepoetin arm. There was a significant reduction in the deciduostat arm. Again, it has been shown that the use in animals like mice model actually attenuates autoimmune hemolytic anemia. The PHI deciduostat increased hemoglobin in autoimmune anemia. It increased the RBC lifespan, decreased the antibody deposition on RBC, and deciduostat also increased the erythropoid maturation in the bone marrow, and it also reduces iron in tissue and serum and suppressive oxidative stress and serum LDH. These are animal studies. We wait for human trials. Again, there is also very exciting evidence that deciduostat protects against complement-mediated diseases, again in the animal models, and it there is data to suggest that it may prevent the symptoms of acute nephritis, glomerulonephritis, membranous nephropathy in mice, and it is worth looking at trials in humans. These are the pleiotropic advantages of PHD inhibition on iron metabolism, glucose metabolism, lipid metabolism, protective factor for acute kidney injury. Again, renal fibrosis and CKD progression is controversial. There are some studies showing benefit. Inflammation is again inhibited. Cancer development and progression, cardiovascular risk and atherosclerosis. The data is controversial, and we are looking for long-term safety benefit. Again, this is a case study which was published in Curious regarding a use of HIF-PHI inhibitor deciduostat in a patient who had EPO-induced pure red cell aplasia, and it was used in this patient of deciduostat led to a substantial increase in hemoglobin. Now, this is our own experience from Fortis regarding prospective single-center study on the efficacy and safety of deciduostat in CKD-induced anemia. It has been presented at the forthcoming World Congress of Nephrology. The study period was January 23 to December 23, and we included patients who were iron replete. So total 120 patients were enrolled, 64% were males, 35% were females. The mean age was 54.2 plus minus 18.4 years, and there was a significant rise in hemoglobin, as you can see, from 8.9 up to 10.1. And what we concluded was that deciduostat is safe and effective oral therapy for the treatment of anemia in CKD patients, offering a viable alternative to traditional EPO injections. And it may also be particularly efficacious in patients who had ESA hyporesponsiveness. Now, coming to some of the guidelines towards the end, these are the Asian Pacific Society of Nephrology guidelines. Strategies when replacing ESA with the HIF-PHI inhibitors and the other way around. Physicians can consider HIF-PHI as alternatives to ESA in correcting and maintaining hemoglobin levels for renal anemia, both in dialysis-dependent and non-dialysis-dependent CKD patients, based on the new data concerning its efficacy and safety. And the guidelines also suggested that types of patients who should be treated with HIF-PHI rather than ESA would include anemia in CKD patients, should be controlled with ESAs or HIF-PHI after sufficient iron supplementation. If patients with good drug adherence desired oral treatment because of various reasons, such as frequency of hospital visits or invasive injections in cases of non-HG patients, then these patients could be offered HIF-PHI inhibitors. If the target hemoglobin cannot be achieved with the recommended dose of ESA due to ESA hyporesponsiveness, then these patients should be converted to HIF-PHI inhibitors. These are the European renal best practice guidelines. So they suggested consider use of HIF-PHI in non-dialysis CKD patients or PD patients where there is patient preference for oral route. They need to avoid injections. The challenges to start or receiving ESAs are there, like needle phobia, unable to self-administer ESAs, challenges to administering iron therapy or when increased iron availability is desired, if there is ESA hyporesponsiveness or intolerance. In hemodialysis patients, if there is a patient preference for oral treatment, home hemodialysis, hypersensitivity or unavailability of IV iron, ESA hyporesponsiveness or intolerance, chronic inflammatory states where like CRP is more than 3, but use with caution in vascular access with high incidence of thrombotic complications, retinal disorders, autoimmune diseases, history of cured malignancies, or kidney transplant patients. And certainly, they should be avoided in patients with the past history of cardiovascular or thrombotic event in the last 3 months, history of malignancy, last 5 years, all patients with polycystic kidney disease, untreated proliferative diabetic retinopathy, macular degeneration, retinal vein occlusion, idiopathic pulmonary arterial hypertension. Key points: make sure that your patients are iron replete, and we need to individualize the dose and maintain target of 10 to 12. Avoid rapid rises in hemoglobin defined as more than 2 grams over 4 weeks. Um, and monitor hemoglobin levels at least monthly until the target of 10 to 12 is achieved and stabilized, and monitor potassium and liver function tests. These are the potential advantages of the HIF-PHI inhibitors compared to ESA in different CKD populations. In non-dialysis CKD, there is the convenience of oral administration, needle phobia, as I mentioned, ESA hyporesponsiveness and intolerance, chronic inflammatory states, hyperresponsiveness or unavailability of iron therapy, exposure to lower circulating levels of EPO, clinical trial on efficacy and data. Efficacy and safety data is available now. Hemodialysis patients, obviously, if those patients are on home hemodialysis, we could offer this kind of therapy. Peritoneal dialysis, all these advantages remain. And kidney transplant patients, again, with anemia, but we lack clinical trial data on safety and efficacy. Currently, trials are going on, and I hope in time to come we'll have clearance for this. To sum up, there are several new erythropoiesis stimulating agents that will potentially improve the management of anemia in the near future, and we are living in an exciting era. The new agents administered less frequently with better stabilization of hemoglobin concentration. There are also promising attempts to overcome the parenteral method of drug administration. There is a real chance that the new compounds will offer much more cost effective than the currently effective erythropoietins, and the fact will certainly improve the management of anemia and the quality of life, and hopefully also the survival of patients with CKD. And they are a unique advantage in tropical countries like ours and yours, where they do not, need to maintain the cold chain. The HIF-PHI inhibitors, they can be safely stored and easily used. So that's another advantage in our setting. So I end on this note, and if there are any questions, since this is a talk which is being delivered in advance, you can have my email, and you can send those questions on email. I'd be happy to respond. So end on this note that in water is the origin of life. The kidney preserves the sea in us, and we must preserve the kidney using our skills wisely. And this is the unique role of renal physicians, or nephrologists as we call ourselves. Once again, thanking the Sri Lankan Society of Nephrology for this opportunity to deliver my talk, and regrets for being unable to come. Thank you, and bye everyone.